Hello, and the topic for discussion now is syphilis. Syphilis is also one of the chronic granulomatous diseases that is usually encountered, and with increase in sexual promiscuity and unsafe sexual practices, syphilis is one of the most commonly encountered disease nowadays in the modern era. To deal with syphilis is actually, as we said, it is a granulomatous disease, right? So what is granuloma? Granuloma is nothing but it is a tumor-like proliferation of your granulation tissue, and we have different types of granulomas again based upon the type of necrosis that they are undergoing. So this type of granulomas include caseous types of granuloma, which is because the type of necrosis that caseous type of granuloma undergoes is so soft and friable. Usually caseous necrosis or caseous granulomas are usually found in cases of tuberculosis. And gametous type, we have gametous type of granulomas where it is actually because of ischemia. Okay, because of ischemia what happens is it actually becomes into more fibrosed kind of tissue there, and it results in gametous type of granulomas, more commonly encountered in case of syphilis. We have suppurative type of granulomas. Again, suppurative type of granulomas are usually caused because of any infection such as bacterial infections, fungal infections, etc., where the central necrosis is usually suppurative type. And these suppurative granulomas we can actually see in case of actinomycosis, histoplasmosis, blastomycosis, etc. We again have another type of granuloma called as fibrinoid granuloma. This fibrinoid granuloma usually is because of a hypersensitivity reaction. It is a reaction because of a hypersensitivity condition. And these fibrinoid granulomas, or it's actually a reaction to a external stimulus. Okay, these fibrinoid granulomas are again commonly seen in case of rheumatoid arthritis, rheumatic fever, etc. Now, this we have actually just now we have seen what are type of granulomas. Now we have various types of granulomatous diseases again based on the origin, based upon the etiological factors. One is infective type of granulomatous diseases, which is most commonly encountered, and these infective type of granulomatous diseases are again based upon the type of organism. For example, if it is a bacterial origin, we see tuberculosis, syphilis, etc. If it is a fungal origin, we see blastomycosis, histoplasmosis, etc. And if it is like a viral origin, cat scratch disease, again a granulomatous condition. When we are talking about hypersensitivity reactions, again we have various types of hypersensitivity reaction, granulomatous conditions also, for example rheumatic nodules again, and foreign body reaction. This foreign body reaction can be either an exogenous foreign body reaction or an endogenous foreign body reaction. In exogenous foreign body reaction, we can see the silk suture material, or we can actually see dusting powder. Patient has inhaled some dusting powder, silica dust, for example, silica dusting powder. This can lead to localized granulomas, that is nothing but foreign body reaction, again leading to granulomatous diseases. Endogenous granulomatous diseases, we have something like tophi. Tophi is also an example of this foreign body reactions, of endogenous to foreign body reaction. And some conditions have unknown etiology, like Crohn's disease is of unknown etiology, again a type of granulomatous disease. So today we will talk about syphilis. Syphilis, in detail about its pathogenesis and its clinical features, and how do we actually treat syphilis. As I actually already told, syphilis is a sexually transmitted disease, usually because of unsafe sexual practices or increased sexual promiscuity, and it is caused by Treponema pallidum, which is again an anaerobic motile spirochetal organism. Usually this syphilis actually manifests in 4 clinical stages. Okay, and it remains infective in stage 1 and stage 2, especially in the first 2 years. It is highly infectious disease. And when we are talking about Treponema pallidum, which is a causative organism, as I said, it is an anaerobic organism, highly motile, filamentous, and it is a spirochetal organism. It is a motile spiral organism, and usually it measures about 6 to 15 micrometers in size. Normally, this Treponema pallidum is very difficult to see on a normal microscopic, hence it requires a specialized microscopy called as dark field microscopy. And when we're talking about the clinical stages of this Treponema pallidum, we have 4 different clinical stages. First is early syphilis, or the primary syphilis. Secondary syphilis, we have tertiary syphilis and latent syphilis. In latent syphilis, we have again congenital syphilis, which is divided into early congenital syphilis and late congenital syphilis. So now when we're talking about this primary syphilis, In primary syphilis, it is actually at the time of infestation, okay? It is at the site of inoculation, we actually see this primary syphilis with normally an incubation period of about 3 to 4 weeks of time. So as we said, it is a sexually transmitted disorder. So usually it is seen in the areas which are more commonly involved, like anal region, the vulva, and also at the penis region, and also at the extragenital region. Sometimes in the palate and oral lesions are more common here, because it actually shows us different the areas which are being involved in fellatio, cunnilingus, etc. Once at the site of this inoculation of this, we actually see something called as Hunterian chancre, and this Hunterian chancre is a pathognomic feature of primary syphilis. Hunterian chancre is also called as sore, and it is usually a hard chancre, okay? And this Hunterian chancre usually seen at the site of your inoculation, which is usually occurs as an indurated papule. Once this indurated papule is present, it will actually erode. The indurated papule erodes and it becomes a hard chancre. In due course of time, what happens? Normally this hard chancre is usually hard in consistency, and it is a shallow one, which is usually a non-bleeding ulcer. Now, with this hard chancre, sometimes what happens, it erodes in the center, and as I said, it undergoes into necrotic material also. It becomes an ulcer. Usually what happens is, this hard chancre has a surrounded edges which are usually raised, and based upon their areas where it is present, it is divided into genital chancres and extragenital chancres. Genital chancres usually seen at the regions of at the glans penis or purpose, at the area of purpose of glans penis, and also at the minor labia minor of at the vulva region. And these genital chancres, because they are present underneath, unless the skin there it is retracted, it is properly not visible. And in extragenital regions, it is usually seen, as we have discussed, in the oral cavity, in the palate region, in the nipple region, etc. And normally this, as I say, extragenital chancres are usually painful when compared to those of genital chancres, and usually they are softer in consistency. Now, as we said, this the Hunterian chancre is usually raised with a hyperemic edge, and this also has a dusky red edematous surroundings around this chancre, which is again a pathognomic feature. The lymph nodes of this primary syphilis, in the primary syphilis, what happens is the lymph nodes are usually enlarged, but they are painless, and a characteristic rubbery consistency is present even in syphilis conditions. The lymph nodes are usually rubbery, and also discrete lymph nodes are present, and this is a pathognomic feature again of your syphilitic lymph nodes. This is a picture showing of extragenital syphilitic chancre on the left index finger. We can see how surroundings are again dusky red edematous surroundings we can see, and if you see the edges of the lesion, they are raised, and also we have a hyperemic edge in the surrounding of the syphilitic chancre. In the oral manifestations, this is again a chancre on the lip. Here also we can actually see raised and hyperemic edge on the tongue, and we also see a characteristic punched out lesions. The ulcers of these syphilitic ulcers are usually punched out, as if we actually punched the area. It appears as a punched out lesion, and the edges are usually well demarcated. And most common oral manifestations are chancre on the lip and intraoral chancres, especially on the dorsal surface of the tongue and the palate, and lymph nodes are enlarged here, especially the submandibular lymph nodes. Now, when we are going into secondary syphilis usually occurs in 2 to 3 months of after the primary syphilis occurs. Actually, to tell you, it is in between 1 to 6 months of time period. The secondary syphilis usually manifests with a generalized rash, again a pathognomic feature. This generalized rash, we can actually have a browny discoloration. This rash is usually with the characteristic dull red or coppery brown color rashes can be seen. And they also have pleomorphic rash. What is pleomorphic rash? Pleomorphic rash is something like it appears in different types, like it can be papular, macular, pustular kind of rashes can be seen in secondary syphilis. A characteristic snail track ulcers are seen. These snail track ulcers are nothing but, normally there are small erosions are present within the mucosa. These erosions, they actually fuse to form a characteristic shape called as snail track ulcers. And this picture shows the snail track ulcers on the back of the patient's back, okay? And We have another characteristic lesion, especially for secondary syphilis, nothing but condyloma lata. Condyloma lata is nothing but a wart-like growth, and this wart-like growth has very huge number of treponema, especially at the mucocutaneous junctions. Your most common sites are again your perineum and anal region. And we can also see generalized painless lymphadenopathy. Similar again, rubbery consistency, discrete lymph nodes are present in this syphilitic stage, that is stage 2. Remember, mucous patches are highly infectious. Stage 1 and stage 2 of syphilis are highly infectious, and direct inoculation, direct touch also can lead to another infection. It can be contagious from one person to another person. When you're talking about this generalized painless lymphadenopathy, it has a characteristic epitrochlear and suboccipital group of lymph nodes which are more commonly involved in this secondary stage. We also have other clinical manifestations like macular syphilitis and papular syphilitis. Macular syphilitis is nothing but the syphilitic lesions or erosions that are present. Syphilitic lesions are usually macular here, where there are multiple flat or slightly raised discolored lesions are seen most commonly on the palate. Macular syphilitis is most commonly encountered, whereas papular syphilitis is less commonly encountered. In papular syphilitis, we see this small papules which will turn into firm nodule-like lesions. Okay, and we have something called as loose maligna. Loose maligna is nothing but a ulceronodular lesion. In this loose maligna, what happens is patient usually manifests with fever, malaise, the joint pains, myalgia. Along with it, patient usually will have a papulopustular lesion which will later undergo necrosis, and it forms into a it is further infected, leading to hemorrhagic brown crust. Hemorrhagic lesions with brown crust can be seen in case of this loose maligna. When we actually see the lesion, it appears like it is a malignant condition. Okay, so this is called as loose maligna, and it has high propensity to turn into malignancy. And other common features are other constitutional symptoms like sore throat is present, characteristic moth-eaten alopecia. Alopecia is nothing but hair loss, right? Patches of hair loss, which is like a moth-eaten kind of alopecia. Pain in the bones, in the joints, in hepatitis, and pain in the bones and joints can be seen. Patient also will have hepatitis and iritis, nothing but inflammation of iris. And other constitutional symptoms like fever, myalgia, anorexia, weakness, tiredness, etc. are other symptoms which are again commonly followed in case of this stage of syphilis. And patient will have acute meningitis. You also see pachymeningitis. This pachymeningitis usually can lead to cranial nerve palsies again, which is again a common feature in this kind of syphilis. This is a picture showing meningeal syphilis where the palms are also involved. Then we have various oral manifestations like mucus patches and snail track ulcers. As we discussed, snail track ulcers are nothing but mild small erosions which are fused to take form of this snail track kind of form. And mucus patches are nothing but most commonly seen on the mucosa, that both on the buccal mucosa. What happens is these mucus patches are shallow ulcers which are usually erythematous, and they are well demarcated with surrounded erythematous areas. Patient usually will complain of hoarseness of voice. Hoarseness of voice is because of involvement of larynx, and also palatal maculopapular rash is again another oral manifestation of this secondary syphilis. Now entering into tertiary syphilis. Usually when well treated, syphilis can stops at second stage itself. However, in untreated cases, in about 35% of untreated cases, it enters into tertiary syphilis. In this tertiary syphilis, what happens is it actually affects the blood vessels. Okay, in this blood vessels, when it affects, what happens? It will have a perivascular collection. This is the blood vessel. It actually have perivascular collection of lymphocytes and plasma cells. These plasma cells are usually because of reaction or hypersensitivity reaction towards your treponema pallidum. When these react there, what happens is the inner side of your blood vessel, the inner wall, the intima of your blood vessel gets thickened, leading to ischemia, and this will further lead to ulcer formation. This is nothing but syphilitic endarteritis obliterans. Okay, this condition is called as syphilitic endarteritis obliterans. Another characteristic feature on tertiary syphilis is gamma. Gamma is nothing but collection of granuloma. It is a granulomatous accumulation of granulation tissue with center necrosis. Okay, there will be central necrosis here. It is actually a hypersensitivity reaction. This is nothing but gamma. This gumma undergoes caseation and sloughing, further sloughing and caseation, then it turns into a gummatous ulcer. Okay. These gummatous ulcers are usually have a well-defined punched out ulcer. It is usually painless and it has a characteristic washed leather slough floor. Okay, the floor is with a washed leather slough. Now, when we're talking about tertiary syphilis, it actually has manifestations as localized manifestations and generalized manifestations. These localized manifestations are nothing but your gumma and gummatous ulcer, and we're talking about generalized manifestations or diffuse manifestations. They enter into neurosyphilis or cardiosyphilis. Neurosyphilis is a condition where actually the particular nervous tissues are involved, and as we have already said, pachymeningitis is a condition where it will cause cranial palsy, right? In neurosyphilis, there will be facial nerve palsy associated with trigeminal neuropathy in case of this neurosyphilis. And when you're talking about cardiosyphilis, it usually involves your cardiac structure or cardiac system, and this is nothing but your cardiosyphilis. When you're talking about various oral manifestation syphilitic osteomyelitis usually involves a mandible, more commonly involved than maxilla, and we have interstitial glossitis or lutic glossitis. Interstitial glossitis and lutic glossitis is again a pre-malignant lesion which has high propensity for malignancy again, and gummatous lesions on the palate. Palate is the most common site, especially for gummatous lesion. You can nicely see a punched out lesion, and if sometimes if it is not treated in time, it can lead to perforation of the palate also. We see syphilitic leukoplakia, and as we already know, leukoplakia was actually first found in syphilitic patient. Okay, syphilitic leukoplakia is one other condition, and neurosyphilis, as we discussed, can cause trigeminal neuropathy or facial nerve palsy. Now coming to latent syphilis. Latent syphilis is actually a condition which is asymptomatic or usually symptomless. However, it always tests positive for serum test in this case of latent syphilis. In tertiary syphilis and latent syphilis also, it tests positive. The patient usually tests positive for Treponema pallidum. Latent syphilis also has congenital syphilis within it, which is again divided into early congenital syphilis and late congenital syphilis. When we are talking about early congenital syphilis, it usually occurs within 2 to 3 weeks, in first initial age group, within 2 to 3 weeks or less than 2 years of age group, early congenital syphilis is usually encountered. Patients manifest with a generalized rash with mucosal erosions, and syphilitic rhinitis is a characteristic feature. In the syphilitic rhinitis, what happens? Patient usually will have this nasal discharge, continuous nasal discharge will be seen in syphilitic rhinitis condition, and this, as the child is very small, what happens is there will be difficulty in suckling of milk. It is again because of this syphilitic rhinitis. And other conditions include osteochondritis. Patient usually have fever, malaise, other constitutional symptoms as usual. Along with it, patient usually have osteochondritis, basal meningitis, periostitis, hepatosplenomegaly, and syphilitic pneumonia is one other common condition. Now coming to late congenital syphilis. In late congenital syphilis, also called as stigmata or late congenital syphilis, we actually see a characteristic Hutchinson's triad. This Hutchinson's triad contains of interstitial keratosis, eighth nerve deafness, along with it we have Hutchinson's teeth. Hutchinson's teeth, what are those? We have screw-shaped central incisors along with a nice band on the incisors, and the mulberry molars are present, which shape of the molars is usually mulberry in shape, this characteristic feature of this Hutchinson's teeth. Okay, along with this Hutchinson's triad, in congenital syphilis, late congenital syphilis, we have saddle nose where the bridge of the nasal bridge is not formed properly. There will be depression of your nasal bridge. Separate tibia, Clutton's joints. Clutton's joint is nothing but painless effusions with subluxation. Usually, most commonly, knee joint is involved. We have parietal bossing and perforation of the palate. Here, in congenital syphilis, we have something called as rugates. Rugates are nothing but normally around the mouth there will be radial scars, okay, also called as eventual radial scars will be seen, called as rugates, like parrot scars they say, and these rugates will cause limited mouth opening of the patient in due course of time. They become fibrous and patient cannot open his mouth properly because of these rugates. And this is a picture showing Hutchinson's teeth. We can see nicely screwdriver shaped incisors in the central incisors and lateral also we can see in this picture. Now, coming to diagnosis, how do we actually diagnose? We have seen the clinical features, we have seen how the pathogenesis of pathogenesis of syphilis. And coming to diagnosis of it, immunofluorescence staining will help us in identifying syphilis. As I already said, because it is a motile organism, dark field microscopy or phase contrast illumination will actually help in identifying this treponema. We have various serological tests, and these serological tests are either lipoidal or cardiolipin antigenic test or specific anti-treponemal test. We have non-specific and specific. And non-specific, we have lipoidal or cardiolipin antigenic test, where we have VDRL test most commonly performed as a diagnostic test for syphilis, and we have rapid plasma regain test, that is RPR. And in specific anti-treponemal, we have FTA-ABS, we have FTA-ABS IgM test, we have treponema palliatum hemagglutination test, and enzyme immunoassay tests are also present, especially for IgG or IgM as a specific anti-treponemal test. Now, once we diagnosed it, now how do we manage this syphilis? For managing syphilis, penicillin G is the first line of drug and is drug of choice. Usually it is given in both primary and secondary syphilis. Usually it can be given for about 6 lakh units for daily once for 15 days. In case of late syphilis, we can actually give extend this 6 lakh units of penicillin for 3 weeks period of time. 2.4 million units of IM single dose can be given. If patient is allergic to penicillin, we can go ahead with tetracycline, erythromycin and cephaloporidine. And in case of, instead of tetracycline, we can go ahead with doxycycline, which is again a drug of choice. And this doxycycline, about 100 milligrams thrice daily for 15 days will be useful. And in pediatric dose, we give about 5 lakh unit per kg, 50,000 units per kg IM as a single dose. As we discussed, in case of late or tertiary syphilis, again 2.4 million international units IM can be given weekly for 3 weeks. And in pediatric dose, again 50,000 units per kg body weight IM weekly once for 3 weeks. Now, how do we actually prevent this congenital syphilis? Yes, we can prevent congenital syphilis, especially when by giving procaine penicillin to the mother as early as possible within the pregnancy. Apart from the management, what happens is we have one certain reaction called as Jarris eczema reaction. This Jarris eczema reaction is nothing but when the patient is actually having, in some few cases, when patient is actually having syphilis, when we are administering penicillin to that, we actually have a sudden reaction, especially only in early stages we see it, where patient will manifest conditions like malaise, fever and rigors. In those, this is called as Jarris eczema reaction. And to control this, we actually give prednisone 10 milligrams for 4 times daily for 3 days before administering a penicillin injection. Especially when we are doing a test dose, patient usually gets this Jarris eczema reaction, and we know that it is a Jarris eczema reaction. Before administering penicillin injection, give prednisone 10 milligram 4 times daily for 3 weeks. So this is about syphilis. We have seen various clinical symptoms, clinical stages, how do we diagnose syphilis, the treatment and the management protocol for it. Hope this covers the syphilis part for you. Thank you.